So type 2 diabetes is essentially a lifestyle disease. The main cause of type 2 diabetes is probably obesity. And it has been termed obese diabetes or diabesity because of the connection between the two conditions. The fat that people store in their tummy is metabolically a very bad fat. And as a result of that, that creates an environment that makes your cells resistant to the effects of insulin. But we also know that people with type 2 diabetes also don't produce insulin at the right time. So there's probably also a degree of worsening or dysfunctional insulin secretion as well. So it's a combination of things. But largely all of this is related to the fact that people are putting on too much weight, they're eating the wrong things, and they're exercising a lot less, which is unfortunately a symptom of modern life, and particularly Western life. But of course, it's becoming much more common even in the developing world, where there are very high incidences of diabetes in countries such as the Middle East and in Southeast Asia. It's becoming a real problem. Well, we have some really important and novel therapies which have come around in the last 10 years, which have been game changers, I think, in terms of management of diabetes. The traditional oral therapy, which we all use, and which had the most benefit in terms of insulin resistance, was metformin. And the majority of our patients will go on metformin as an initial therapy, but sometimes it's not tolerated very well, and people suffer the gut problems of metformin, sometimes for reasons of poor kidney function. They can't take metformin, and for other reasons, other intolerances as well. But we have a lot of modern therapies coming out, tablets as well as injections, which have really been game changers. And I think the biggest drug that has come out fairly recently are the class of drugs called the SGLT2 inhibitors, which essentially cause you to excrete glucose through your urine. And they have been remarkable in not only treating diabetes, but also helping with weight loss. And obviously that is an advantageous combination when you've got people who are somewhat overweight. But they've shown some really remarkable data in protecting people's hearts, as well as their kidneys, and preventing people getting heart failure, all of which are very common in diabetes. And in fact, the biggest cause of death in people with diabetes is related to the heart and vascular disease. So anything which we can do to protect the heart in the first instance is always going to be a gold standard almost. So much so that the drug agencies, both in the United States and in the UK, made it compulsory that all new diabetes drugs coming out had data on cardiovascular protection. And these SGLT2 inhibitors are absolutely fantastic in the way that they not only protect the heart and people from dying from heart disease, but also protecting people from heart failure and kidney failure. So that has been a real revelation. Along with them, there is a drug class called the GLP agonists, and they are largely injections. There is one at the moment which is an oral therapy. But the injections are marvelous at helping people lose weight. They make people feel full or sated, and they help bring their glucose down as well, partly by making people feel full, but also by another mechanism, by secreting increasing doses of insulin when people eat. So their benefit is multifactorial, so lowering your glucose, making people feel full, helping people lose weight, but they too, like the SGLT2 inhibitors, have proven benefits in cardiovascular disease. So they will prevent people dying from heart disease. We haven't seen the really incredible data we've seen with the SGLT2s in terms of heart failure or renal failure, but certainly they are very good at helping people lose weight. So much so that some of their class now uses weight loss agents and not only for diabetes. We, of course, have another array of other oral therapies, which include drugs such as the DPP4 inhibitors, which are a similar class to the GLPs, but not quite as powerful, and without the advantageous data. And then we also have other older drugs such as pioglitazone, and the sulfonylureas like the glycosides, which also have some benefit. Like any type of diabetes, if your blood glucose is raised for a long period of time, you will get complications, and the complications can be divided into those for the what we call the microvascular complications, which are the very small blood vessels, but also the macrovascular complications, which are the big blood vessels that go around your heart, down into your legs through the big blood vessels there, and into your brain, and they're the ones that cause the death in diabetes. The small blood vessels tend to cause what we call the morbidity, or problems with your eyes and your kidneys and the little nerves in your feet, so lack of sensation, for instance. So those are the problems associated with diabetes, but they really only occur after a long period of time. In the short term, people do get symptoms, obviously, of diabetes, but they don't get necessarily particularly unwell unless you get something called a diabetic ketoacidosis, which is something you see in type 1 diabetes, when your blood sugars are very high, and you developed ketosis, which is a formation of acids as a result of the breakdown of fats in your body, and those acids create an environment in your body which is very toxic, and has still quite a high mortality if not treated urgently. So diabetes is diagnosed these days often by a blood test called an HbA1c, which is a marker of how sugary your red blood cells have been over a 3-month period. Now, 3 months because it's the duration of a red blood cell. Red blood cells are just a protein which glucose latches onto. So glucose latches onto a lot of proteins, and a lot of the mechanism of destruction or damage to the cells is by the attachment of glucose to these proteins. But hemoglobin is a convenient marker that we can measure, and not long ago we found out that actually can be used as a diagnosis of diabetes. And it's a simple way of testing people to see if they have diabetes. And if you're above a level of 48 millimoles per mole, then you can make a diagnosis if people have symptoms of diabetes. So the classical symptoms are people feeling very thirsty, people feeling very tired, people passing a lot of urine, they may have problems with their vision. If they have those symptoms with a raised HbA1c, then you can make a diagnosis. In the past, we used blood glucose for a diagnosis, and if your fasting glucose was above 7, then again, with your symptoms, you can make a diagnosis. But if you don't have necessarily symptoms, and often a lot of people don't, you might need 2 markers with a little bit of separation in time between them to establish a diagnosis. So you might need a couple of HbA1cs, or you might need an HbA1c with a fasting glucose marker. We don't often use what's called a glucose tolerance test these days, but it is still available. And if you take a specified load of glucose, which is about exactly 75 grams, and you drink it and then test your blood glucose 2 hours afterwards, if your blood glucose is greater than 11 at that point in time, then again, this is another method of diagnosing diabetes. So as I've mentioned before, the main symptoms of diabetes are feeling very thirsty, passing a lot of water, generally feeling tired, and possibly having visual problems as well, so blurred vision as a result of glucose causing a shift in fluid levels in the eye, changing the shape of the eyeball. But often a lot of people will not have any symptoms at all, and that's the worrying thing. People can live with very little in the way of symptoms for many months, sometimes even years. And the very excellent and early study called the UK-PDS study found patients presenting with diabetes often with complications already because they had diabetes and they hadn't been detected. Now, of course, that was a few years ago now. That was in the sort of 80s and 90s, whereas nowadays we're a lot more acute about finding people with diabetes, and there's a program for detecting people with pre-diabetes even. And we talked about the HbA1c, and actually the HbA1c, when it's anywhere between 42 and 48, gives a diagnosis of pre-diabetes to people. And this is often a warning and a good way of trying to reverse things before they actually develop diabetes.